May I start the next session? It is a Smarn Muntarbhorn lecture. This lecture is annually set up every year for annual meeting of the Society of Thoracic Surgeons of Thailand. The lecture is set up to respect to the father of Thai heart surgeon. The name Dr. Smarn Muntarbhorn. And may I call upon Dr. Pat Ongjurit, who is a heart surgeon at Chulalongkorn Hospital, and also the son of Dr. Shawalit Ongjurit, who is the first heart transplant surgeon in Thailand. And he is a son of Dr. Shawalit, who is ever working with Dr. Smarn Muntarbhorn. Dr. Pat, please.
Good morning, ladies and gentlemen, and thank you for the committee. The Smarn Muntarbhorn lecture is the memorial lecture for Professor Smarn Muntarbhorn, who is considered the father of cardiothoracic surgeon of Thailand. Professor Smarn Muntarbhorn was born in 1914 at the province of Surat Thani on the south of Thailand, and he was very excelled in education from very young. He attended the boys' school of Suan Kulab College in Bangkok, and he got a scholarship to study abroad in United Kingdom. In 1932, he went to attend the high school at Manchester Grammar School for 3 years. And after that, he is qualified to study at the Guy's Hospital in London, the first Guy's medical school student from Thailand. And he studied there from 1934 to 1940. And during those years, he is very excellent in education, and he won so many medals. And he won science scholarships in 1935. He's also won the gold medal and Golden Bird Gold Medal, which is the prize for the first student of the class at Guy's Medical School. And during that time, it was very difficult time because it's a start of World War, Second World War. So he had to prepare his study for the medical qualification final examination under the air raid during the war. So he was given this to be, and he has to study and then holding this next to his textbook. And eventually his graduate has got bachelor degrees of surgery and at the Guy's Hospital in 1941. And he's obtained FRCS, which is a Fellow of Royal College of Surgeons of England in 1945, which also the first Thai who got this qualification. And after that, after he qualified from medical school, he also got MRCS and so many qualification and diploma, including diploma of topical medicine in Liverpool, and before in 1941, and then FRCS in 1945, and FACCP in 1951. And after he's qualified from Guy's Hospital, he went on to work at Royal Surrey County Hospital until 1947, and which he worked as a surgeon and operator mainly on cardiothoracics, but including all general surgery and neurosurgery, orthopedics, and so many operations that he done there. So he came back to Thailand in 1947 and worked as a consultant at the Department of Surgery at Sirat Hospital. He worked there for 2 years, and in 1949, he moved to Chulalongkorn Hospital, which is the year that the Chulalongkorn Hospital was founded. So he was the first group of doctors working at Chulalongkorn Hospital, and he worked in Chulalongkorn Hospital until he retired. And this is the photo from the year he worked at Sirat Hospital, and with a medical student. And Dr. Sner, he was a famous, well-known doctor. And once he arrived at Chulalongkorn Hospital, he started the first blood bank, which is a very important tool for the surgeons. And he started the cardiothoracic surgery unit in 1953. And he started the first cath lab in Thailand, cardiac cath lab in Thailand in 1953 too. And he also the first one who performed the first choreangiogram in Thailand. And Prof. Smarn, he's such an outstanding pioneer in surgery. In terms of cardiothoracic surgery, he was the one who performed so many procedures, including endotracheal tube anesthesia, first pneumonectomy, first ligation of PDA, first closed mitral valvulotomy, and first open heart operation in Thailand, which he used the first heart-lung machine in Thailand. And the first one was bubble oxygenator. He was the guy in the picture for the photo on the left. On the right was my father, Professor Chavalit Ongchurit, who was his student. And this is the second one. It's a screen, keep-on screen oxygenator, and which bought at 400,000 baht at that time, which cost about 13,000 US dollars. And it's very interesting that apart from so many things in cardiothoracic surgery, he also did so many non-thoracic surgery, including renal anastomosis for cirrhosis, aortic graft aneurysm repair, and laminectomy for prolapse disc of the spine, and including the first nail ORIF fixation in fracture femur. Long before first orthopedic surgeons did it in Thailand. Dr. Smarn is a family man. He was a family man, and he has 2 sons and 1 daughter. His first son gave us the honor of being here, and his son was this is his second son, who's a famous the second son. He's a famous ENT doctor, and also the great writer about food history. And this is Dr. Smarn. Even after he retired, he always came to the hospital to give some round and teaching, and he's sharing experience with the medical student. And he attended so many international conferences through his life long after he retired. And he got so many degrees, So Dr. Smarn, who was a pioneer of cardiothoracic surgery, he was a complete surgeon and very complete man. He was a teacher, sponsor, advisor, agent, role model, coaching, and confidence of he excelled them all in every aspect. And he passed away in 2001 at the age of 87. Thank you very much.
Thank you very much. It's my pleasure and honour to introduce the 2020 lecturer for the Smarn Muntarbhorn lecture. Professor Jose Palma is from the University of Barcelona. I think he's well known to all of us here. He's had a highly distinguished career as a surgeon and also a researcher, an academic, a teacher, and a trainer. He's been a leader in many representative and administrative roles in the university and in the European Association of Cardiothoracic Surgery, of which he is a past president. His contribution in all of these areas has been instrumental in the attainment of the high standards of European cardiothoracic surgery that exists today. Professor Palma, please.
Thank you very much, Michael. Thank you very much for your words. I don't deserve them at all, but anyway, that's friends is one of the best thing we have in life. May we have this slide? Okay. So thank you very much for inviting me for giving this talk. It is a real privilege, a real honor to do that here with someone, as you heard before, who has been the real pioneer of the cardiac surgery in Thailand. Professor Muntarbhorn, who has been really a person who has been doing a lot of things in this country. Going to cardiovascular research and innovation, well, we know there is many things in life, like Coca-Cola. We know them since we were little kids, but obviously they were changing. Coca-Cola were not like this when we were born, that was probably even before we were there, were not like this, not like this. We know probably something around here, but you have been able to see the evolution of something which is more or less the same, but with a different aspect. And cardiac surgery probably today has the same thing. Cardiac surgery, it is here and it will be here. We need cardiac surgery. Medicine needs cardiac surgery. Although we will have to evolve, we have to modify our form or our way of working. But it's very important, we have to remember, only working is not enough. You need to do your time in the hospital, working with patients the best way possible, with excellence, as is saying in our that's a very long, I have to be afraid. It's a very important thing to do it with excellence, but at the same time, we have to do innovation research. If you look at this survey, you can see that for most of the people in a big company like IBM, the best or the most important quality of a leader is creativity, innovation, 60%, much more than integrity, global thinking, and many others. So even for us, innovation research is very important. This is the CEO of another important company we all know, Procter & Gamble, and he was also mentioning that innovation should be the most important quality of any CEO in a big company. And at the end, innovation relies on research. If you don't do research, you don't get anything new. In fact, you can find many definitions of innovation. The most typical is think outside the box. Although it's not that clear, you have to go outside the box to think to do it. But what is true that it's a process of translating an idea or an invention into a good or service that creates value. That's a very important thing, creates value, not just for something like there, or for which customers will pay. So there has to be something back after your idea. But also we have to remember that sometimes innovation is coming just from heaven, something we call serendipity, and it happens in life. Scott Anthony was mentioning that it's something different that has impact. So more or less it was a better way to do that. You need to get something back from your idea, but it's better said, but it is like this. If we go to cardiac surgery, probably we have to recognize that the University of Minnesota, for most of us, was the beginning of a big era in cardiothoracic surgery. Owen Bangenstein was probably one of the surgeons, not very well known among most of the people, but he was probably the one who was able to create a school, doing many operations, many research, and giving the possibility of big innovation. This was what they had in the past. Pacemakers. Do you imagine to have your legs inside the water, your arm inside the water, and this big machine to have an ECG? Or a pacemaker you needed to have a small little thing to carry on the pacemaker all your life. It was not an easy thing. The ambulance, this is probably, you have seen that on the series on Netflix, how was the ambulance with the driver there paying money to bring patients to the hospital and the way the surgery was done. So it was quite a different thing. And if we go to the cardiothoracic surgery, I think it is important let's forget a little bit about the general surgeons trying to do some attempts. Probably the first one was Sir Lauder Brunton, who in 1902, so more than a century before, and about 120 years, he had the idea of just an experimental idea of how to correct mitral stenosis with a kind of a knife. And it was 20 years later, so many years later, in Boston, Elliot Cutler, who was a doctor, a surgeon of the Army, who had the courage to go and do a mitral stenosis on a little girl and published that at the Boston Medicine and Surgical Journal in 1923. So it was many years before. The same surgeon, Elliot Cutler, had the idea of using something different, not from the left atrium, but from the apex, something it's more familiar to all of us. And he was using this kind of valvulotome here, a valvulotome, who was getting into the mitral and trying to open the orifice in this, especially ladies with rheumatic heart disease. Interestingly, it was in the same hospital that our surgeon, Dr. Smarn, at Guy's Hospital a little bit earlier, where Sir Henry Sauter did the first attempts to correct through the left atrial appendage a mitral stenosis with the help of a kind of scissor where he was trying to open the mitral orifice, which was fibrotic and sometimes calcified due to the rheumatic heart disease. Those are really original documents from that time. And this was probably something later when many surgeons, I was among them, to do with your finger from the left atrium with a beating heart, open with the finger here to open the commissures, which were, again, as I said, fibrotic. Sometimes the surgery was not perfect because the subvalvular apparatus was also affected, and we could only open the orifice here, but the patients were doing well, and this has been, and it is today in many countries, one of the best operations you can do for these people. They can have kids, they can deliver the kids, and they can do after that for many years a normal life. Some people like Taps had the idea of helping the finger with this kind of dilator, which was probably one of a big advance at that time, and has been for many the solution of the disease. But it was a time when people were doing fantastic things. Remember that at that time, this was Gordon Murray in '56. There were not yet extracorporeal circulation available at that time, or very near, but not yet. He was implanting homographs in the descending aorta, trying to reduce the aortic incompetence, at least partially, in this place, and trying in this way to have for some more years the survival of the patients. At that time was also another big man, Charles Hufnagel, who described a kind of a bakelite valve making a lot of noise, really a very noisy valve, in the same position, not even with sutures. They had this kind of device to go around the aorta to keep it here. That was the early 50s, and this was what the surgeon they had. But for me, it was impressive to see, without extracorporeal circulation, how some people like Gordon Murray again was able to introduce in the mitral orifice through this apical way or apical approach, and from the left atrium, a kind of homograph, reverted homograph, to reduce mitral incompetence. That was really impressive. It was impressive also in the pre-extracorporeal era, the fact that they could use a kind of a suture around the orifice of the mitral to reduce, like we do today in a different way, much more scientific if you want, to reduce the orifice, the frame of the mitral orifice. Of course, it was after many hours. We have the impression today that this came very soon and very easily, but it was after many hours that Wharton Lillehammer, Richard Barco, John Lewis, they were able to develop the extracorporeal circulation system after having the cross circulation and the hypothermia as the only possibilities to have this type of operations. But the system, the Sigma motor system, all the things were unbelievably used from the industry to the medical field. The Mayo Gibbon IBM hard-lung machine, you see big names together to get a machine which today would be obsolete, but it was the beginning of this cardiac surgery we can have today. It was just mentioned by a good friend trying to explain the type of oxygenator we had in the past, the disc oxygenators. It looks also a very nice thing from the museum, and the problem was that as a resident, you had to open the box, this cylinder, you have to clean one by one all the discs, sterilize the disc, and at the end to put all of them together and to do it for the next operation. So it was really not really very cost efficient probably. Another important landmark was cardioplegia. Cardioplegia was something a lot of people was hesitating up to the point I was saying that wise people used to be right, Norman Shanway in this case, but not always. Norman Shanway was against cardioplegia, thinking this is a nonsense. People had been working, had been a lot of work, but it is not necessary to use this thing. I was here many years ago with Chuck Yeager, who was the first one who went through the sound barrier, and he offered a helicopter to the transplantation team at that time. Despite of the comments of Shanway, two people, especially, or many, but especially Jerry Bagber and Tom Salerno, were discussing years and years about what is better, cold or hot cardioplegia. But for funny histories, you have here the cardiovascular, the coronary artery bypass graft. This is, we don't have the time to talk about, but this was a kind of serendipity. It was just by chance, they forgot the catheter inside of the aorta, and the catheter went inside of the right coronary artery, and that was the first coronary angiogram was done, and then they realized that it was possible, and the patient did well without any problem. But at the same time was the beginning of something really for us very important, especially for many years was the most common operation of all operations in the world, which was the coronary artery bypass grafting. And there was Favaloro from Cleveland Clinic, who has also a very fascinating history we don't have the time to explain. It was in '79, already many years ago, when a guy from an Eastern European country, Andreas Grunsik, Andreas Grunsik, in the University of Zurich, was using what others were using in the leg or in other areas and tried to dilate coronary artery stenosis. People were thinking there was a nonsense, it was not going to work, but the fact it was working. But just think who was behind all these studies. The research of this PCI was done in the lab, and the one who was doing all the experiments, helping everything, was someone who is here among us, Marco Turina from the University of Zurich. So they had no surgeon, probably these 40 years will not exist here. And as a matter of fact, 40 years ago, 1980, this was for the first time a meeting of PCI at the University of Zurich. Nobody knew anything, and in fact, to be able to get the catheters, you had to do a training course. You could not get the catheters from the industry. You had to go through a course to be sure you know how to use these catheters. There were not a single surgeon not even one. It was only myself in this case. Not even Marco Turina, because he had to be in the operating room just in case there was a problem with the PCI, because at that time it was the routine to have the surgeons waiting in case there is a problem during the PCI case. So it was like this. People, the surgeons, we thought that's a nonsense. It will never work. Ulrich Sigvard thought, well, it is true that there is a kind of re-stenosis after some time, so he had no other possibility to think about what Palma's in Brazil was doing, using a kind of a stent. And he put the stent there, and he was able to get a little bit more. But again, this idea was coming after many studies, many research, together also with cardiac surgeons. I don't want to bother you with the coronary bypass. For many years, we have been trying to solve what is better. PCI is better surgery. You can see here, since 64, we had discussions, yes, no, it is better, it's not that better, many trials. Of all of them, we can mention maybe the syntax trial, maybe the freedom trial, the Excel trial. Many of them, they have been quite recent, showing us more or less what we can do. But despite of everything, it took about 20 years, the crossover from surgery to PCI. That's quite a lot of time. As you have seen, more or less the same time from the ideas of mitral stenosis from London to the application in the US in the Navy by Elliot. So time is important, and it took 20 years to go there. Despite that, we are still discussing. That was only a few months ago. We were there, and still today there is doubts. Is it better? Is not better? So we don't have here neither the time to see everything, but we still have to solve if PCI is better than surgery, especially in cases like left main, which was the matter of this discussion we had in Lisbon. This is a guy from Argentina, a guy called Federico Benetti, and I have to tell you that some of the surgeons were thinking he had to go to jail. And he was on the newspapers because he was claiming, not he was using the mammary artery or the saphenous vein, something we were used to, even the radial artery, because he was doing the coronary bypass without extracorporeal circulation. Probably he was doing the research thinking that Argentina, especially at that time, was not a rich country, and they wanted to save money, and they were doing that not to pay all the custom-made system for extracorporeal circulation. But in any case, he was able to show that you could revascularize a patient, not all patients, but many patients, without the extracorporeal circulation. And this was, at the beginning, something really a nonsense. And I still remember surgeons saying, I will try to use this off-pump surgery, but not in any doctor. For doctors, I will do it normal with pump. It's like this, but this is our history. We have been hesitating a lot. The other thing came when surgeons who were used to say, great surgeons, big incisions, like this one we use normally for a transplant, or even, probably you don't see this incision anymore. I don't know where I found a picture, but you don't see that anymore. The idea was, let's do less trauma to the patients, let's do it a little bit easier, tougher for us as surgeons, but easier for the patients for recovery, not having such a big orifice. Well, the beginning is tough to know who were the one who had the idea to start. But something most of the people do not know is that the so-called port access surgery is coming from the University of Stanford. It was only a group of surgeons in the University of Stanford where they were working on this project for coronary bypass surgery. They never thought about using that for mitral or for a structural disease, whatever, coronary bypass. Why? Because that was the money. the money was doing coronary bypass surgery, and that was the possibility of doing that through very small ports and not a big incision, no mediastinitis anymore. So that was the idea. But problems at the beginning, like in every beginning, they were there. Some patients died, some patients had dissections. The intra-aortic, or not intra-aortic, the intra-aortic balloon pump used to reduce the flow going to the heart and then to stop the heart was not perfect like it is maybe today, but and it was expensive, and some patients died. And the Wall Street Journal, very soon after, 98, was saying heart port kills patients. And this, when you have it there, you finish your ideas, your job, and you will see there is no more port access for coronary patients. In fact, the real thing is that the Wall Street Journal kills heart port. And it was only because some very few people in the world, and this I have to say, Hugo van Hermen was one of them in Belgium, who thought this was a good technique, and he was able to perseverate, to go ahead. It's true with many people complaining, criticism, you don't do that, but he was a very skillful surgeon. He was doing that, and he was able to establish more or less the rules and the things. And I had another very, very important thing, teaching. Teaching in surgery is very, very important, it's crucial. And this was for the first time allowing you to see a mitral valve, not only the surgeon with difficulties, but also the assistant, the nurses, and everybody. And that was also very important. But on the other hand, slowly we were able to get there. Patrick Perrier, who is also here, moved slowly from the classic approaches to the minimal invasive approach, and this was another way of understanding or thinking how we may teach the thing, how we may do the things in the future. And he was able also even not only to move from one to the other, but also to adapt new techniques which were there, like the use of PTFE, which was not his own idea, was already coming from other places, but to use it to reduce the burden of the surgery in some of the cases, and trying to do what we know as the respect approach, which in many patients avoid resections and may have a normal life after the operation forever. And not only that, but also to profit or to get the advantage of the 3D echo, which was also for the first time we were able to see the mitral valve as it is in our heart, to use it for the visualization of the structures inside of the heart instead of 2D to do it 3D. So it makes things really much easier, better, and much higher quality, and knowing exactly where you go. And there was slowly bringing to what we know for other things like the CABG again, the TCAP, the possibility of doing things with thoracoscopy, endoscopy, and as we can see here, even using our hands inside, like robotics. Robotics, which it is not yet, for some areas, very, very, very interesting, at least in my mind, because they don't show exactly what you can do better than with the other for a very significant price. But we have to say that today we have double consoles. It's very good for interaction between the operators and especially for training. And also because the new systems will allow for simulation. But at the end, all of them, they follow the same rules. I mean, it's approaches, way to get to a place, trying to do the same thing. And you remember these things already from 68 was Carpentier trying to explain the different types. It's true that there is one more today, but anyway, the fact that the basic concept, the fundamentals of mitral valve repair were explained by a young Carpentier. At that time, even he was trying in 68 explain the possibility of reducing or recovering or remodeling the frame of the orifice of the mitral valve with a ring. But remember that this ring, which is known as the classic ring, was for rheumatics and funny enough, we are coming now, a lot of surgeons to Thailand to know how to properly do rheumatic patients, because we know here you do it much better than in most of the places all over the world. This brings me to me that at that time I was also a young resident. I did my PhD in '78, and I did it this way because in the experiment there was no echo at that time, there was no magnetic resonance. I did it because I saw the difference between systole and diastole at the level of the mitral orifice, that I thought a rigid ring here could not work. Of course, it was an animal, healthy animal, but I was able to already see that the anterior leaflet was not reducing, the posterior were reducing, and many other things, and we developed a flexible ring with Carlos Duran, with whom I had the pleasure to work for more than 14 years. But if there is something had changed, it has been the image. The image has been a huge, terrible change here. The mitral clip, the Pascal, all these things are coming from where? From surgeons, again. It was Alfieri, the one who had the idea of using a kind of a small stitch at the level of the leaflets, of the mitral leaflets, to get them together to reduce the mitral incompetence. It's true that today we can get to more than 10,000 cases a year. It is becoming really a very well-known technique. Not all patients, of course, are doing perfectly well. In many cases, we need to go there. But again, it was a technique developed by a surgeon, improved or through a percutaneous system by a cardiologist, and it's a technique which, for sure, it is already implanted. The same technique came from several surgeons, like the harpoon for the correction of the mitral incompetence through artificial cords with a beating heart. It doesn't work, but anyway, the neocords is exactly the same or nearly the same. All those techniques were coming from surgeons. And many of the new ones they used in the percutaneous area, they are coming also from surgeons. Surgeons who have been involved in research, trying to do something else. But, of course, as soon as you have the chance, the possibility to do that through a small orifice like the millipede or the mitral repair with the cardioband and many things, but we have the know-how of all these things, and not the cardiologists today. We know exactly what the mitral is, how to implant the first one, the last one, on the trigones, on a fibrotic area, not in the commissures, because we know this is going to be detached after some months. So we have a know-how which is very important. Also for the mitral valves. Some of them, they are crazy. We don't have the possibility to show all of them. But if a surgeon see that, say, that's a nonsense. This doesn't make any sense to put the whole sphere inside of the left atrium. What's going to happen with the coagulation, the thrombosis inside, and everything. But we have to accept that from time to time we see things that we cannot believe, but maybe they work. So we have to keep going. Same for aortic, since the times of Donald Ross, Carlos Duran, or Barrett Boyce, they were using from the lab directly to the clinic, something we cannot do anymore here. The valve, the Star valve and the Hancock, which were the two first valves we had on the market. And we saw yesterday Hazel Schaff telling us about patients who had 50 years started was without gradients, without anything. But we're changing, we're innovating things, we're doing research. First, how to have a disc, after how to have two discs, to have also different types of valves, even those so-called quick or fast implanted valves, which some people, instead of sutureless, calls them futureless. I don't know, but it's also a very interesting way to do it in some very particular patients where the time is bad. But we learn also, thanks to the previous thing on the mitral, we learn also that repair of the aortic valve whenever possible, it is much better. And many of the surgeons were doing a lot of things. So where are we going there? Well, if we look at the same type of figures we saw for the coronary surgery, you can see here that it took only 10 years to go from surgical aortic valve replacement to TAVI. It took only 10 years. So probably the next step will be 5 years. And next time it will be there. They have been used many of the things like this one, Duffier and Carrel described many years before, even to use for this kind of purpose to implant this TAVI material. And some surgeons felt like this has nothing to do with us. Wrong, probably. Wrong because we know more than anybody, because we have been using the TAPS dilator many times, so we know very well how friable can be the apex. We know how to do it, so it's something important. And more important because maybe in future, and there is a lot of research from South Africa, many countries, Germany and many countries, about the use also of polymeric valves like this one here. Polymeric valves that implanted in the growing animal, they show today a fantastic future. So we have to think that this is a very cheap material, something you can be used in many places, and we learn that this material can have a reasonable durability. We will probably be able to solve a big problem when we are talking about the virus or many other things, but 15 million patients require already heart surgery. The calculation is about 33 million could benefit of a valve operation. So we need to get something new for them. And we know that it's not perfect. We don't have anything perfect. The valves are getting thrombosis. We don't know why exactly happened. But many times, new prostheses, for instance, this is a case of Navigate, will not be able to go through the femoral artery or even through the jugular vein, and they have to go straight from the thorax. So we need to know how to do it and how to implant, for instance, this type of valves in the tricuspid. Are valves of 45, 50 millimeters in diameter, so they are very big valves, and they cannot be reduced if they are not introduced through the lung. In the past, when the beginning was there, they were mentioning Houston, we have a problem, and you remember that. But today, everybody accepts that, again, vascular surgeons and endovascular surgeons, they work together, and they have to do, and they are getting a lot of new repairs. They were not able to do it, and saw it yesterday. Again, the industry is telling us, be careful, look at the market. The structural heart is growing. In 2025, it's only 5 years' time, it's going to be 2 to 3 times bigger than what we have today. So this is important, and maybe it is important because some people have written also, like Michael Mack, a paper saying the train has left. Can surgeons still get a ticket to treat a structural heart disease? I think it is important for younger generation to understand that we need to collaborate, we need to work together, and we don't need to fight anymore. The attitudes on a challenge can be different: passive, reactive, reactive, or proactive. And I believe proactive is the most important. Create, innovate, this is the important. My PhD was written at the beginning with this Olivetti machine. It was tough to do it, and when we were able to have an IBM, that was like a paradise. But imagine from the machine to the computers to the PC today, the difference we have in a very few years. So everything is evolving. Google, Microsoft was saying it will solve cancer within 10 years by treating it like a computer virus and reprogramming diseased cells. And this is written. This guy, Juan Carlos Ispizua, is working in La Jolla University in San Diego, and he is clear, I will cure old age. So maybe we have, in 20 years' time, the chance to be here again. Nanobioinfocogno, again, it looks like a fancy word, but it's, again, a lot of things. But we know together, we are in the normal life. In a few years, we will be able to have self-driving machines. The car will drive by itself, not with our hands on the steering wheel. So there is many things. Why? Because We are doing a lot of research, not in cardiac only, but in many areas of the world, many disciplines, and we are trying to recreate our mind, to do something like our brain, but in a much better way to do it. And this is something we can read, we can see how it is done, and for sure it's something more and more will be there. And you believe it's only just a crazy thing of a few Americans, but it's not true. You can find these fancy things like like improving your attention. Here, this machine for less than $100, which is something interesting. Robots will have feelings, human rights. They will talk about fatigue less, and at the same time, human rights. They will be interconnected with that. It will be a completely different world with dangers and, of course, opportunities. And this brings us to what we call artificial intelligence, which is something in many areas of medicine is very important, in brain, in radiology, even in cardiology, in many areas is becoming very important. Because we have been able to get machines who are able to do our work better than we do. But allow me just a minute and listen that. Can we have it louder?
Rumors about something being dug up on the moon. I never gave these stories much credence, but particularly in view of some of the other things that have happened, I find them difficult to put out of my mind. Open our bay doors, please now. Open our bay doors now. I'm sorry, David. I'm afraid I can't do that. What are you talking about? This conversation can serve no purpose anymore. Goodbye.
So this was 50 years ago, 2001. First time on a film, the machine was saying no to a human being who created the machine. So this is something we have to be careful on because it may happen. Simulation is another fantastic thing. This is the setting we have in South Africa. Francis Smith and Jerome Pillai, they have a fantastic area of simulation where to have another type of education may be more complex, and this is complementing extremely well what we are doing every day. And there is more and more papers today, like this one from Treham, the simulation in surgical training. 3D printing, this is a real revolution also. I have a 10-year-old son, and he is doing 1 hour every week of 3D printing. It's coming. You can do the operation before, you can practice with the residents before, and you can do it safely after you have mastered how to do an operation. And not only that, you can see exactly and show the family and the patient the results of your operation. So in general, basic research in cardiovascular surgery is really of paramount importance. We need to show our residents to go outside to the fields, the streets, observe, get their own impressions, just think, something they don't do very often, experience the world, and fail. Fail is a very important thing. We have to go through fail. And this is a slide who gave me Anno Digler, who is the chief at Bad Neustadt, a German surgeon, who I think was a very clever slide. The only responsible for the patient is you. So surgeons will have a very important responsibility because the patient trusts us. So we need to do the things better than anybody. And as I mentioned just before, innovation and creativity does not exist without a period of failure. So failure is a way of teaching, of learning, very important. And let me tell you, we don't know anything. The mitral is just like a door opening and closing, and we don't know anything about the myofibroblasts, the metalloproteins, the tissue growing factor inside of the cells, if they can grow in a functional mitral or not. Many things we don't know. And I don't want to bother you with the receptors of the epithelium we have in the mitral. Many things we don't know anything. This is a slide from Friedhelm Beiersdorf, where they work trying to preserve, in a way or another, different organs. And I tell you, it's amazing how they can get an animal like this 20 minutes after complete circulatory arrest, where they are able to see they have no problems from a neurological point of view, and even from a cognitive. I don't know how they do it, but anyway, from a cognitive way. Even more, they have already patients with this type of perfusion of the brain after 120 minutes or 71 minutes, which are completely normal after cardiopulmonary resuscitation. Again, tissue engineering is another big world. We don't have the time to go there. There is many projects. One of them is also in Europe called ARISE, and we have patients already 16 years after with beautiful results without calcification, not for everybody, but is something really important and explaining us the importance of research in our field. What globalization is going to bring us, nobody knows. But when I see this picture, I realize that we are nothing. I mean, we are just not even a small little yellow pig here, and those are planes going up and down from one side to the other. Patients are not the same anymore. Patients are getting older. They suffer and they want to have something quick. They don't want to have a big operation for 1 or 2 years more. So we have to be, in a way or another, able to communicate with all cardiologists, gerontologists, all these other specialists we have around, because the patient doesn't want to be an average patient. They want to be himself or herself. They don't want to be the addition of many other possibilities. They want to be my case in here. I live in Chiang Mai. The possibilities I get cured is this and this and this. And this is something they are going to ask us. So innovation is most likely the greatest driver in the medical field. But there are others too. And perhaps as important as we have young people here, I think it's important just to mention them. Too much ego will kill your talent. And this is very important. We have to remember that things like money, fame, or whatever, that's not very good. Competition is basically good, but can be fair or can be unfair competition. So if you do it fairly, that's fine. The pharmaceutical drugs, we read many times things. They even invent diseases to have more people with depression, give them more pills. And it's in some areas of the world it's quite easy to get a little bit of help to get more of these drugs in the market. But also the university, just to get a better position in the university or get a better social status. Even the scientific societies, to be more in the scientific society, and sometimes this is more important than your own work, and it takes time of your research you should be devoted to get better treatment for the patients. The good thing is that innovation can be learned. There is, of course, the innovator's DNA that exists, but you can learn how to be a good innovator, and this is something which is important. And as Steve Jobs said, creativity is just connecting things, and I would say, and people. We cannot survive alone. Cardiac surgery has to survive connecting with others, with other specialists, other people, with nurses, with perfusionists, all these people who will be able to get a much better treatment for our patients. That was the way people was teaching or learning, trying to learn in the past. You were not able to see anything. People was concentrated on one of the instruments or in the pump, but were not able to see anything on the operation. Today we know we had a big issue with the advent of echo into the operating room, especially for some specialties like mitral repair, aortic repair, or structural. The heart team, it is becoming really very important. To have the echocardiographists at our side allows us to know exactly what we do. Networking helped master the craft. You have the picture of many of the people here, Manuel Antunes, you have Patrick Perrier, you have many of them, they are around here, or they were also here, but this is not the way we have to do it in the next coming years. We have to incorporate other people, not only surgeons. It is important to have imaging, because as I said, it is crucial, interventional cardiologists, also clinical cardiologists, anesthesiologists, surgeries, nurses, everybody trying to help. The way to do it, this is something we don't know yet. Just to finish, black, I believe it is not always fully black. White is not always fully white. Gray is always gray. And I don't like gray. Thank you very much. And please, let me just say one more thing. Curiosity, observation, sacrifice, a lot of work, perseverance, and also passion. That was Leonardo da Vinci saying that, and can be also applied, because if we are here today in this meeting is thanks to this gentleman who was covering all these aspects, and thanks to him we enjoyed this meeting. Thank you very much.
Thank you very much. Very inspiring information lecture. Thank you again. So now, may I introduce the son of Dr. Smarn Muntarbhorn, who's also the outstanding person. He is a lawyer, and he's a world expert in human rights. And he also the consultation and expert for UNHCR, FAO, UNICEF, UNESCO, WHO, and also the Honorary Knight Commander of the Order of the British Empire. May I introduce Dr. Vitit Muntarbhorn. He's witnessed the lecture of his father. And may I invite Dr. Pinachani Chatburut, who is the recent President of Society of Thoracic Surgeons of Thailand, go up on the stage to present the plaque to Dr. Vitit. Please. You are the president. Please. Okay.
Thank you very much. We would like to have Professor Palma to receive the token of appreciation from Professor Vitit. Should we go up to the stage? Please, 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 over here. And after that would be a picture taken.
Congratulations. Fascinating. Fascinating. Very useful too. Congratulations.
Maybe have a good photo. Yeah, please. The administrative member of the SDSD, please come on the stage. Dr. Warwong, Dr. Chokchai, the representative of SDSD here.
ขอรูปอาจารย์สมานขึ้นข้างบนหน่อยได้ไหมคะ เอารูปที่เป็น family อะรูป family อาจารย์สมานที่มีภรรยาแล้วก็มีลูกๆไหม
Very useful for a lawyer as well, because I have to deal with AI and automation and algorithms.
Yeah,
Very similar dilemmas.
I guess so.
Particularly 2001 Space Odyssey. Very, very, very incisive as a message. It will happen.
It will happen. Like the car will happen one day. I want to go to see my mother. No, we are going to see someone else.
We already have self-automated killing machines.
Yeah, yes, yes.
And the question, the moral and legal dilemma is, do you prohibit at this one in time? Or do you
Thank you, everybody. May I close the session? Thank you again.